everyone. I think you all can hear me now. Am I audible? Just please confirm.
Yes, Andrea, you're right. Ankush?
Should I start then? Yes. Somebody confirm that I am audible. Good morning, everyone. I am Anjula Roy Chaudhary, a biostatistician, and today it gives me an immense pleasure to welcome all of you to our very first session of the Biostatistics Training Program on Oncology Researchers. This training program is today being conducted by Homi Bhabha Cancer Hospital and Research Center, Muzaffarpur, as you all know, and we are associated with StatsCure with the aim of training research methodology and biostatistical understanding among like us oncological researchers who are working with research methodology, biostatistical understanding, and also with the healthcare professionals persons. This session will be conducted, we will try to conduct it within every 15 days, and it is going to be a continuous platform for learning, discussion, skill development in the field of biostatistics and clinical research. Today, I would like to inform that I would like to inform that we are very fortunate to have an excellent panel of statisticians who are part of our this program, who are guiding us in this program. The panel consists of Professor Atanu Bhattacharjee sir, a renowned biostatistician with vast expertise in research and academics, and myself, Oindula Chaudhary, and along with me there are also Mr. Akash Pawar and Mr. Ankush Shetake is also there, who is a statistician, biostatistician at Homi Bhabha Cancer Hospital and Research Center, Muzaffarpur. Together, all of us, we hope that we are going to make this session informative, interactive, and beneficial for all of you participants. In order to encourage active participation, I firstly would like to inform that it is a continuous learning process. MCQ, assessment questions, everything will be shared with all of the participants after once the session will be completed. So I would request each of the participants to successfully submit their successfully submit their questions or answers procedure and their responses to us. Once their responses have been submitted to us, they will be awarded with the certificates of participation as a recognition of the involvement in our workshop. At this moment, I would like to express my sincere gratitude to Homi Bhabha Cancer Hospital and Research Center. And now it is my privilege to honor and invite Dr. Kumar Prabha sir, Director, Homi Bhabha Cancer Research Center, Muzaffarpur, to kindly deliver the opening statement for today's session. I would, I don't know if sir has joined, but I would like to have some words from Kumar sir. He has helped us a lot. He has always guided the statisticians and clinicians also in medical oncology field and another field. And it is a research oriented workshop, so I guess no other mentor than Kumar sir will who can motivate us for this workshop.
Ankush sir has joined.
Sir, we'll join you in 5 minutes, sir.
Okay. Okay. So while we are joining, so any of you would like to introduce yourselves, or we can have some time then. It's a voluntary. If you want to introduce yourself, that would be really good.
I guess that will be help us also to interact with the participants, and furthermore, if they need any kind of question answer or interaction, that will be great for them also. If volunteers, if anyone wants to at least participate or discuss something.
So just to add few points, as Vandirala said, we will be having, we will touch different topics with statistics along with the clinical research uh, and what we face during, for conducting any research. That sort of topic we will touch one by one. Today we are going to touch the very basic concept that p-value, where it is being used, what the conceptual background, how to make interpretation. So that we will touch. It's completely non-mathematical way we are trying to present. So all about the discussion will be here today on that ground. So today is the first day. So we are waiting to join Dr. Kumar Prabhas so to give some introductory talk. So then thereafter we will be uh, start our discussion. So it will be basically interaction. So not only the purely presentation. So Vandirila, Akash, Ankush, they will also have some interactive points. They will raise some questions, query, and then we will have elaborate those points. And meanwhile, if as a participant, if you have any points, please hold us and you can also speak and better let us know your point. Then it will be also helpful for us to deliver on that. And as Vandirala said, after that we will be having some question answers. Mm, we already have your email ID. We will send it to you. And once you submit your question answers, then we will be giving you certificates or, as confirmation of your attendance. Just we are waiting for WhatsApp to join.
यार है दूसरे का लेगा जहाँ पे मेडिसिन शुगर हम कहाँ पे बात है मतलब एक बार देख ली देख ली एक बार देख ली हाँ बाबा टेप हो गया और बैग कर टेप कर दिया बुखार चेक करना वाला तो होगा बुखार चेक
Ankush sir has joined.
है टेप कर दिए कपड़वा कर देते हैं कर दिया नहीं
Ankush,
जा बाबा कपड़वा तो खत्म हो गया नहीं है मैं रुक के देख लेते हैं कहीं दूसरा नाम से भी आ जाता है
participant, if you are not deliberately talking anything for these workshops, could you mute yourself, please?
ठीक There's a lot of echo.
Thank you. So
There's a lot of echo.
I think now we can start. We are going to start it once Kumar sir join. Then we will stop and ask him to give some introductory talk. I think it's better to start now.
Yes, sir.
Okay. So, okay. So today we will be touch about this p-value, and now let's start on that then.
Yeah. Hello, sir, am I audible?
Yeah, you are audible.
Yes. So, thanks everyone for joining this, and yeah, we look forward to create such more sessions. While starting with sessions, we were really keen on designing the course of this, like what lectures and topics we can deliberately take and put it in front of you, so that we are on same page and discussing what is new, going around, and we are touching the same points or not. So the very first topic that we thought would be very much of interest, the p-value, right? uh, and that's where this p-value topic came. And that is my questions as well. Like, we see a lot of thing going with the p-value. Sometimes it has been criticized, sometimes it is taken as the most proof of concept for the trials answers and everything. We would like to know more about the p-value, how it is taken in biostatistics in clinical research, uh, and what are the conceptions behind it.
Oh, I think sir has joined. Uh,
Yes, sir.
Indrila?
Hi, Atanu.
Hello,
Good
hello,
morning,
sir.
everyone.
Hello, sir.
Hi. So, from my side, this is a very good initiative, and I, thank and congratulate, StatsCure to partner with HBCH RC Muzaffarpur and to initiate this activity. And the topic is also very good, which is something most of the clinician wants to know. We are so dependent on p-value. So good, we will learn from all of you how to really interpret it. And my best wishes for all the future classes, what you are planning to do. Thank you. Thank you. Please take it forward.
Thank you, sir.
Thank you, sir.
Thank you.
Akash, could you start now?
Yeah. Yes, sir. So that's what my question is. Like, we see p-value around a lot in clinical research, especially in oncology research, where most of the proofs and evidences are relying on it. At the same time, we see that p-value is also criticized somewhere, uh, while reporting or while making decision on it. So, what is about the p-value? What is around it? Can you explain us?
Yeah, so let's start with that, that typical graph where it says, I think my slides is visible. Yeah.
Yes, sir.
Yeah. So it's a old story. See, 1920. So R.A. Fisher have some experiment, and he coined that term, the p-value probability, and from there onwards, it's take it forward. That in real, day to day, all that research work. Yeah. So let's talk about this graph. So here you can see that this graph is split with two color. One is blue and another is red or brown or whatever you say, brown red color, let's say. And whole scenario, whole story we split into two part. One part is a blue color, that is ongoing, that is, s- no variety, nothing different over there. And then another part is that red color, that we are having this, we are expecting something different could happen. So you can relate this point with any sort of idea that we deal with in a real life. Like say that, yeah. So let's say we are talking about the drug impact. So I can come the drug story or clinical trial story, but let's say simply every day you are coming on time on office by 9 to 9:15, let's say. So same thing. So there is not any variation on that, on all weekdays, if you say. So these are all these usual things. So that's been presented in this blue color. But some reason with weekdays where there is no holiday, nothing, but still due to some reasons you may not coming in the correct time, could not reach office on correct time. So that's an exceptional things. So that's been parked over this red color area, and that's called, the p-value. So that's basically all sort of things. Now it's come to this clinical trial context where we are talking about the drug or interventions, and here all the story here. So if you are anticipating or getting any results that makes difference or no difference, that is this, binary outcome. So either you are going to give any drug or intervention to patients, to your patient, or you are anticipating that effect would be there, then you are anticipating, expecting that effect would be coming in this brown color area. If it is not, the same thing is going to give, then you can anticipate the results is becoming here. So that's that broadly we are going to say about the p-value concept. Obviously, you can see that there is a vertical line goes from bottom to top here, and it's up to us, and we will discuss where this vertical line will stand. It would be stand here, or little left side, or little right side, or both side of this tail. That's it's a different, altogether different points to be discussed. But in nutshell, it's it's usually we are trying to see this picture, this scenario that is ongoing, that's the same with existing one or the prior one, or there is something different we are anticipating. If you are something different anticipating, that would be remarked through this p-value. Hope I could give you answer, Akash.
What is to be considered about when the tail of probability, when we say this tail is about, it's very narrowed here and it is very higher there. So what is about is to be considered and not to be considered about the effect size with respect to the p-value then through this graph?
So see, one thing is that as we say that what is to be considered. So I would say what is to be considered means there are couple of elements help us to consider this p-value, and obviously one of that is a sample size or the patient population we are saying. As I said that we are going to start with every day with 9 or 9 5 15 aim to reach office, but somehow we could not. Or let's say we are talking about the drug, we are giving 10 people or 20 people drug, or we are not. So how much strong we are going to generate evidence? Somebody can say, look, if we give the drug to 10 patients, 1 out of 10 patients worked it or not worked it. So that is, but another person's going to bring the same outcome from 100 patients or like 1000 patients. So that's giving you much more impact. So if somebody can contact with 100 patients and they're saying the same thing, 1 out of 10 patients never worked or worked, so then obviously your effect size is going to be up over there. So yeah, so once we are going to say about the p-value, one of the ingredient is supported or give you the boost up of this p-value, definitely the effect size of this, um, of the study. Yeah.
What do we consider in a nutshell that this is to be considered, can be considered based upon the p-value, and this we cannot consider based upon the p-value? Is there some kind of differentiation?
One thing definitely we can say that, see, we will talk about it, but what we can consider, could you give much more explain on that, what we can consider?
Okay. Whether if the p-value is, so whole idea about doing an experiment is that replication. So
Yes.
I assume that the p-value talks a lot about replicative effect, like uh, in real life, whether if we are going to do this study number of times and how likely we are going to have the same difference or not. So based on this p-value, can we say that yeah, this effect is not due to chance, it is definitely a replicative effect and can be taken into
Yes.
consideration?
So exactly. So if you see the background or theory behind to create this the p-value, see, it's purely and probability representations. So out of 100, how many times we are going to have So in background, once we talk about this p-value, we are going to say that if the same thing repeated 100 times, and out of these 100 times, how many times you are going to get the similar results or not similar results. So as we started with this, the two example, I will keep on touching these two example, like reaching 9 by 9:15. So 5 days in a week, you reach 1 day late after 9:15. And the same thing, it's an week story because we are not going to calculate for entire year for a person. So let's say out of 5 days, we have seen that one day, any single week, randomly pick any week, let's say from for this month of May, first week uh, of May, one day somehow you missed and reach later than 9:15 to office. And based on this sample of the 5 days week, we are going to say that if the same thing happened for 100 days, out of these 100 days, how many days we are going to be late? Is it more than 10%, more than 20%? So that probability is going to be nothing but this probability by p-value is going to become on that. So while you are talking about, or if you give some drug to 10 patients, or giving say one patient or two patients are having effective or non-effective, what about the interpretation you are going to say by p-value? It being saying that if you do the same experiment 100 times, not on the 100 people, 100 times, then what is going to happen? So one experiment, 10 patients, out of that you are going to get 2 and 3 positive or negative results. So if you conduct the same experiment 100 times, then how many times, say if the scenario is going to have, so what the threshold of that, what is the probability of that you are going to get the similar results on that. That's the way interpretation should be have.
So can we also consider this as an error limit, like whether doing it for 100 times, how many times are we doing error? So is it at that
Yeah,
level? So
yeah, so that is that way. Yeah, definitely.
understood. So so
So
what is
should we go
about,
to next slide then,
yes, sir.
or you have any point, anyone having any point, clarity? No. Okay, yeah, please hold us and raise any point, comments if you're having.
So as we discussed, this tells about the yes and no of about the probability. What tells in a nutshell?
Yeah, so one thing is that I think you can only see my presentation screen, right?
Yeah.
Only one thing, yeah. So yeah, could you repeat again? Sorry, I just little,
Yes.
yeah.
So is it the same that we were talking about? The studies, what is considered about the p-value and what is not?
Yes.
But we
So
likely
see,
say, right? Sorry.
yeah, yeah,
But we
please.
likely say, right, if the p-value is significant or not, the drug is working or not.
Yeah. So what is saying and what is not saying here? So see, if it's tell about the probability, and whenever you are talking about the p-value, fundamental thing is that split is that, that hypothesis been always been taken over there. And that hypothesis takes that we are aligned with the hypothesis, and the hypothesis also split with null hypothesis and alternative hypothesis. Null says that no difference is there, like drug is not going to have any impact on that. You are not having any disparity to coming office every day. So that sort of things would be there in the context of this null hypothesis, where your alternative hypothesis is saying that yeah, there is a disparity, there is an impact, there is a positive or negative, that is a impact is positive or negative, that is a different story, but there is a thing. So a tail, a probability under the null hypothesis, so p-value is saying about a tail probability that we see. It's a slide that one side tail, the probability on the null hypothesis. And then he's saying that how surprising the data are, the null were true or not, and then everything been consolidated with a continuous number that is between 0 and 1, not as not as a binary or yes or no. So basically whole story between probability terminology been taken, how much it is 100% true, 100% surprising, or 10% surprising. So again, you are coming late of age, so it is a 10%, 100%, 50%. So that sort of things are going to come in. What people generally get confused about p-value, by looking the p-value significance, they started to saying that drugs works, but it's not. It's never say that drugs works. It's it's never say that it's due to the results. It's never says about the measure of effect size. It's never says about the guarantee of the replication. So there is a some myth obviously is there in p-value, and people get confused on that. So these are the limitations of the p-value. And many times we without that we say, once we say that p-value is significance below 0.05, then we started to saying that drug is impacting. But be cautious, like it does not mean that always it is impacting or effective on that.
Yeah. Can we look to this as an hypothesis statement, like how the null hypothesis and alternative are compared between based on the p-value?
Yes, yes. So we are going to support either null hypothesis or alternative hypothesis by looking p-value. Somehow we can take that decision that we are aligned with null hypothesis or we aligned with this alternative hypothesis or not. That in nutshell we can say.
So why it is? That's what another question is, like why
Sorry
we
to
are.
sorry to interrupt you, Akash. I guess we have a question right now in our chat box.
Okay,
Yeah.
let's see. If the experiment is significant based on p-value, then how it is not reproducible? Okay. Hmm. Anyone want to touch the point?
So I guess this goes likely with the hand that we cannot rely much on the p-value somewhere. Like we nowadays, as we take the decisions, we should look more about the effect size and confidence interval rather than uh, making decisions based on p-values. So I guess this goes around that where the reproducibility can be concerned if the p-value is significant, and based on that only we make decisions.
Yeah. So while we are saying about, so there is, if you split this question, like experiment is significant based on the p-value. So once we are saying that experiment is significant, so yeah, so once we're talking about the p-values being considered, so definitely the theory behind generating p-value, obviously it is saying that 100 times if you conduct the study, out of that, how many times you are going to see the same results. That is one story. So it's never saying that significance difference is there or not. It's saying that if you are going to have the same study conduct 100 times, how many times you are going to get the similar results. That is the story of generating after the having the p-value. Now, once you are getting that the results are coming different, significance means significantly different towards intervention arm as compared to existing arm, or both the arm are having experimental and one is having make impact. So that results, so that difference can't be considered as reproducible in the context, because it need to be generated, it need to be considered different points like confidence interval, like other studies, other conducting study. What we are going to say, particularly by looking this p-value, if the p-value is itself generated from your study, it's never say that it's never guaranteed of the reproducibility for other studies. That I can say that it's never guaranteed you to the same results could be considered for other studies. As far as your experiment is done, if you conduct the same study, same experiment in similar fashion 100 times, what is going to come out of that? That come can be called from the p-value. So there is a thin layer on that.
And that's why there is a lot of evidences being placed now based upon the effect size and confidence interval.
Yes.
And the importance is given to it.
Excuse me.
Yeah.
Am I audible?
Yeah.
So, yeah, I wanted to add one thing. So regarding that question, I mean, what I feel is one number of sample size that also matters actually. That is a major, key factor. So it's like a p-value. Usually in the layman terms, we apply to check the significance and it's like the significance, right? So it's like if the p-value is less than 0.05, it means the chances of that random error is less. So it means it gives the significance. So like there are some factor when we design experiment based on our hypothesis and so sample size also is a key thing. That's what I wanted to add in that. So based on that, it depends on that we can it is reproducible or not.
Yeah, so sample size definitely in a couple of slides later we are going to touch it. So sample size is definitely one crucial point over there to produce p-value, no doubt about it. But I would say that sample size helping us to say that how strong we are to making the statement on the p-value. If the same p-value can be generated from small sample from large sample. It's hardly matter what is the sample size you are going to consider. But that the point is that once you are having big sample size, more sample size, we can say a much more louder way that p-value strength of the p-value, I would say. So if I'm just repeating again. So if you're getting p-value from 10 sample, if you're getting 1000 sample, the same p-value we are going to generate. But the p-value generated for 100,000 patients would be considered a much more louder manner than generated from 10 patients data. Other than that, there is not any difference impact of the sample size to generate the p-value, whatever it is going to be high or low. Does it make sense?
So, just a follow-up, just an example wise, if I say like we have a study of 10 samples and 10,000 samples, and we know the effect is not positive. The treatment is not working good, whether it is in 10 sample or 10,000 sample, and we are generating the p-values both at both the places. So I am likely to understand that if the drug is not going to work, the p-value is not going to be significant here and there both as well. However, as per what you said, I understand that because of the sample size being large here, which is 10,000, it is not likely that I would go get a significant results just because it is having a large sample, and though it is a no effect, it is not going to give me less than 0.05.
Exactly.
Okay.
So your p-value is, you can't change your p-value directions by increasing sample size. That is the story.
Yeah. But
So
somewhere in clinical trials, are we not?
we are
Yeah.
that the thumb rule is that you can't divert your p-value. You can't divert your p-value by increasing sample size. It's basically it's a random value, it's a result. So if For example, let's say you have not, as a candidate, you have not studied properly, and if you've been asked to give 10 mock tests, your result, what is going to have the mock test without preparing any exam, any theory on that, without any preparation. If you attempt 10 tests, the results, whatever you are going to have it. If you attempt 100 tests, result is going to be the same, right?
Same. Yeah.
Because you have not prepared. So point is that, and between 10 test and 100 test, if you prepared yourself better way, if you make this much more sensible, then definitely 100 mock test is going to help you. Your p value is going to be high. But by default, we are saying that we think that if you are not prepared with first 10 mock tests, then definitely you are not going to have the preparation, more preparations for 100 test. That's the thumb rule. And based on that, we are going to say. So that's why p-value is this results you are going to get out of 10 test or 100 test. So if you're still not prepared, even 100 test or 1000 test, your performance is not going to be better. Is it? No, it's not going to be better.
Understood. Yes, sir. So, how, sir, further this evidence, as we know, like if the p-value is less than 0.05, we reject the null uh, uh, we reject the hypothesis and null hypothesis, and we say that the drug is working, it is doing good, and the sample size that we calculate is all assumed to be having based on this one assumed effect that we take into consideration while designing the study, right?
Yes.
So, so I guess this talks about the null hypothesis and the alternative.
Yes.
And select.
So see, the analogies behind that, we are having the drug is innocent, drug is having no impact, and you are generating evidence from your trial data, and then you are going to discard your null hypothesis. So we are always attempting to discard our null hypothesis that it is drug is innocent, and that's why these p-values comes over there. So, and if it is a evidence that yes, drug is not innocent, that's making no more impact on that, then verdict is that we are going to reject null hypothesis, we are going to consider alternative hypothesis, and we are going to say your drug is having impact on the patients over there. So yeah, any more questions on that?
But as we saw in the first graph, and this relates to me. So
Earlier
if
one?
yeah, the first one, if we fall into this, the p-value is this little margin of this graph. So is it always the same margin? And if we fall under it, we are okay.
So here, see, as we say that now let's say link with this fall region. So if you say that null hypothesis here, so drug is innocent. So drug is innocent means drug is going to come in the blue color line. And drug is not innocent, drug is having impact. That's mean the results obtained from drug is going to have this tail. Now it's up to us that we are going to consider these red regions completely right tail, or we can take it little shift over there. If you see that R.A. Fisher's 1920 paper, that based on that the p-value and all this story came, and they in the footnote, they only footnote, there is not any theoretical support, there is not any theoretical justification why p value should be considered 0.05. Only he said in the table footnote that 1 out of 20 experiment we can get these results. So we can say that experiment is doing differently. So that's 1 out of 20 become 5% threshold benchmark of the 5% p-value as a 0.05. But to be honest, there is not any standard theoretical justification why p-value should be 0.05. People over the years, over the century, people consider p-value as 0.05, and that's why it stand over there. But theoretically, if your p-value is very minimal, that's mean you are going for 0.05 to 0.01, then definitely we are going to shift from this red color line towards more right side. And if it is not, then we are going to have red colored side. From 5% to 10%, then it will come to much more left side. Sorry for that. So, so, so right side towards if you're going to reduce your p-value, and left side it is going to have if you increase your p-value, means 0.01 to 0.1. So 0.01 means 1%, so it will go completely right side. 10% means 0.1%, so it will go to left side. Now, again, we can, whatever that, the confusions comes over there, the p-value is that we always say that it's in a one direction in one right hand side, but definitely there is a possibility this p-value can be split into right and left side both. What does it mean? Look, when we are talking about the p-value, we never say about the direction. We are saying about the significance point or the difference is there. Difference could be positive, difference could be negative. What does the difference could be positive means? The drug is impacting positively. What is negatively means drug is impacting negatively. So whatever the existing drug is there, if your new drug is doing so bad, then also we are going to get the significance p-value. So having the options from the left hand side also gives this opportunity that there is a possibility drug could be in another line also, another way also. Drug could be completely useless as compared to existing drug. And that's why this theoretically the p-value can stand in the left hand side and right hand side. But if you are very confident, you are going to have the experiment be done only one side. That's mean you are saying no, my benchmark, my new drug is always going to be either positive or at least at par the existing drug. Then we are in a positioning to consider in the right hand side only. Otherwise not.
So, that is like two-sided hypothesis we are talking about. And
Yes.
does that means that if I am designing a phase 3 trial with two-sided hypothesis, p-value, significance, uh, does that means that I'm taking into consideration that drug might go into negative side? Maybe now that I'm saying that the effect size would increase or the response rate would increase from 10% to 20%, for example, 20% to 30%, and considering two-sided, I'm gonna test for 20% to 10%, whether it is decreasing or not. Is it that? Uh, and
Yeah.
I see
Yeah.
that the two-sided is taken into consideration, but this negative, do we label it as negative effect or something? When if we
Yeah, so so negative definitely. So now see, broadly p-value is coming having these differences in differences there or not. It's never say about the directions. As you said that it is a positive, two-sided or uh, that's basically split your alternative hypothesis into two part. As a alternative having the provisions to make the alternative that alternative, what is that alternative is saying that there is a difference is there, difference presence over there. Now the difference is in a higher level or lower level. From 40%, if you are having 50% or more or 30% or below, that's this adjustment or provisions to make this alternative hypothesis. And that's why, as you said, that then we can in the phase 3 study, we could have the provisions to make this split into right hand side and left hand side both.
However, in phase 2 studies, I have seen people might consider one-sided p-values as well or significance to test for. Is it just
Yes.
because that they are very confident that phase 2 would work?
Yes,
Whereas,
it's all about confidence. See, it's not
okay,
only about the numerical value. It's all about the biological rationality is going to have how body everything. It's not the drug you are going to test it. It's not coming from some randomly. All the justification is there. So there is always standing point why not to consider one-sided. And that's arguably makes sensible because once you are having investing so much time, efforts with a new drug, Why should we go randomly consider going the experiment where you never know that is going, it could go in the negative way also. Conducting retrospective study, doing exploratory study, that is a different story. And they are also the p-value concept come. But while you are talking about this phase 2 and phase 3, very random control trial, random clinical trial, then definitely we should not give any room that, your we should not give any room to consider any molecule or any dose or drug that could go in a negative way, obviously. That's a standard. But theory is always helping you to go in the different direction as well. So that support is always there.
Yeah. Sir, and as you said, the myth about the limit or this threshold, we have seen that phase 3 are mostly the 5% where we consider the significance level. And phase 2, I have seen like people have gone till 0.25 as well while designing and concluding phase 2 results. So,
Yes.
is it allowable, and what is the background behind considering those limits for these two phases? Again, the same
See,
p-value.
so basically, see, it's basically a line to be considered. It could be 5%, it could be 10%, it could be 1%. As I said, there is not any theoretical support or logical justifications why should go for 5%. But if we are going to reduce, why to consider it's 5% or why not to consider 10%? But it's true that if you move from 10% to 5% to 1%, then obviously we are restricting our selection criteria. Means we are going to be much more filtering over and over there. So you can consider p-value is a filter. If you are going to pass with 10% p-value, then risk is there. This study is not very rigorously scrutinized, or there is a high possibility if you conduct the same study in another patient populations, you may fail over there. But while you move from 10% to 5%, that usually people consider to 0.05, then it is very high chance that you moved away a little bit from 10% to 5% region. So you are saying that if you conduct the same study in another populations, you most likely will not fail. Now again, if you reduce from 0.05 to 0.01, then the same story goes over there. So from 5% to 1%, if you drop your p-value, so you are going to be much more stringent your criteria, or much more restricted with your criteria. So again, you are going to say, if you have your p-value below 0.01, that's mean if you conduct the same study in other populations, is very unlikely you are going to get the different results. Different results means here you are going to say that drug is impacting. In another population, you would say also drug is impacting. Here you are saying drug is not impacting. The same thing you will also say that drug is not impacting. So that's the story behind that. Now, in reviewer point of view, manuscript point of view, people very rigorously consider p as a 0.05 as a benchmark. And if somebody going to say, for example, if you are going to say the p value is 0.59, sorry, 0.49, no, 0.049, let's say, not exactly 0.05, let's say 0.049 or 0.051. What the decisions we are going to take it? Just my question now.
That the trial
So
is
two
working.
scenario coming, I'm just repeating.
Yeah.
In one experiment, you are getting your p-value 0.051, not exactly 0.05, 0.051. Another experiment, you are going to get 0.049. What the call you will be going to take?
So me being a statistician, I would say it is significant, being 0.049. And if it is 0.051, I would say that it is not significant. I'll state it directly. Yeah. I'll make my decision on the threshold, which has been considered.
That's the point. So no. So nobody said that p-value should be below 0.05 or exactly 0.05 should be called as a significance. Why you are linking that significance terminology only with 0.05? If it is a 0.051, still drug is working significantly. Only it's our myth that we always stand with 0.05. Strug and many study got in drain because we were very particular to consider 0.05 as a benchmark, and we are getting 0.051 or 0.052 and we reject it. I understand because but once we are stating the law rule that we should consider 0.05 as a benchmark, and below that we are not going to consider, and above that we are going to consider, sorry, below that we will consider and above that we are not considered, that absolutely fine. But we are also losing that opportunity not to test the drug in another populations, because it's very likely that 0.051 or 0.052 in another study could come into another direction, could be lesser than 0.05 as well, and we can't lose that opportunity if you are very particular about 0.05. So again, 0.05 is a mindset people keep on considering for ages.
Sir, one reason I said like I will consider it as significant or not significant is because maybe I had uh, I had been there while designing the trial, and while designing the trial we had taken this significance level as 0.05. We calculated a sample size, and we considered an HR. Suppose like the drug will reduce the HR to 0.65, and the sample size would be this much based upon this 0.05 significance, and we calculated the sample size, and wrote it in our protocol. So now then, after the analysis, when the analysis is done, it is coming to me like the 0.4049, yeah, or else if it is 0.051, I'm taking the decision based upon that because I have already assumed some things.
That's a
And
valid point.
yeah,
That's a valid point, because as your point, you're going to say that you want to restrict with the pre-planned whatever you make the commitment. Definitely. So that's arguably correct. So if you say, always we say before exam, what should be the passing mark? It should be 60% or 70%. And after exam, if you performed not good, then obviously we are not arguing that, let's say we say that 60% is the passing marks and you're getting 59. Arguably, we are not going to say that, okay, reduce the passing marks, cut off, make it 55, then I am going to pass it. We never say that. We never do that. So always definition wise, we need to go with that. That absolutely correct. I completely agree with you. But scientific point of view, I'm saying, once we completely discard that drug or drug experiment just because of it could not pass the 0.05 threshold benchmark, but somehow it was near to that. I'm not saying that p-value is 0.15, that's sensible to consider, but if it is a very nearby locations 0.05, then arguably we may not lose opportunity. You never know that having some heterogeneity in the changes in the population, you can get the different results altogether. There is a very like chance that likelihood you can get the different result, positive result in future. So that's my point. But as you said correctly, we should not deviate from predefined protocol, and that's why the sample size, everything stand over there. And
yes,
here
sir.
is the slide, so where we can split the p-value 0.05 into two part, 2.5% and 2.5%. So we're having these two opportunity on that. So as someone asked with this HBCH Muzaffarpur. So look, this is this slide. So see, p-value is never going to change here. If you can see my slide, p-value is not going to be changed here. It is always going to be the red color line will stand with the same place. But once you are increasing your sample size in the x-axis, if you see, you increase your sample size, then this effect is going to be dropping, p-value, same true effect is going to be dropped from top to bottom. And after certain time, it is going to be, saturated. It's not going to be below that. So obviously, uh, same thing is going to have it, but same results is going to be habit, but somebody is making with sample size 200, somebody going to have the same p-value with 50, or somebody going to mark with 500. Obviously there will be difference in terms of the impact of the sample. Sorry, impact of the sample size over there.
Sir, it would also depend upon the effect size that we are considering. Like on 50,
Yeah,
if I'm considering 50% effect size, on 100, if I'm considering the 50% effect size, the 100 is going to be significant. Is it going to be true? So then the sample size is making its effect on the
yeah.
conclusion.
So basically sample size is you're boosting your comment, how it's not boosting your p-value calculations. P-value
Yeah.
is going to be remain same. Again, I'm going to say it's your boosting your confidence, how loudly you can say that my p-value. Somebody appeared in 4 or 5 times some UPSC exam. I know in Bihar it is very people very like to link with this UPSC. If somebody attempt to the 4 exam and never passed, so what happens? So very, you are not going to get pass. It's very unlikely that you are going to pass again in UPSC, even if you are not attempting for after 4 attempt. But if you pass with one attempt, there is a likelihood that if you failed in first attempt, there is some chance that you can get, passed in second and third round attempt over there. So think this number of attempt as sample size. As much as you go, your sample size, your attempt is going to have, you are going to confident that you are in which place, you are in a positive place or negative place. Yeah. And then definitely it's p-value sync with this sample size then. Okay, so if it is done, then we will go some example where and how different p-value would be considered over there. Yeah,
So I have also seen like we are the for generating the p-value, we obviously do some test
yeah,
on based upon the type of data, or in oncology mostly the survival data.
yeah.
But there are a lot of tests, so they work in the same manner to calculate p-value.
There are two things. Oh, one thing is that the the idea to weigh the intention to calculate the p-value, and second thing is that the way p-value be generated, calculated. Intention to calculate p-value irrespective of oncology or non-oncology or type of data is always same. Intention is going to be remain same like this. Intention is going to be remain same like this. Intention is not going to be changed. But as I said that based on the type of data we are dealing, the way calculations goes, theoretically it being different in different scenario, because we have to accommodate the calculation of p-value aligned with type of data we are dealing with. There are various type of data in oncology, as you said, that we are having time to event data, sometimes not time to event data, sometimes follow up data, sometimes no follow up data. So different scenario would be having different way calculation of the p-value, and that's why you need to bring different statistical tool to calculate the p-value. But idea or intention is going to be always remain same, to judge the null and alternative hypothesis, that is going to be remain unchanged. So for example here, that one example is that prevalence of iron deficiency across different tumors and its association with poor performance status. disease status, and anemia. It's published in Annals of Oncology long back. So, but the mean hemoglobin level of cancer patients was significantly lower than WHO reference, that is 12 G per DL for women and 13 G per DL for men, used to define anemia. So they try to find out among this cohort that they are dealing with that cohort, what is the impact of the how what is the iron deficiency value was there, and they say that among male and female, what is the mean value they are going to calculate, and there they consider that WHO reference value as the 12G, 12 and 13 for male, for women and men. So now see, so once we are talking about this WHO threshold, so there is a always having some general population mean hemoglobin level we are talking, and that's been taken as a 12 and 13 for female and male. Now they conduct the study for 3,526 patients, and out of that they find that 1,755 were having anemic at baseline. The cohort mean HB at was significantly below the reference threshold. So then they make this statement on that. So now come to this point, how we can make that what stand over there. So this is a simple Excel file we are going to say it. It's a obviously the toy and example over there. So they not split the patient into male and female. Just they enter the data as patients as with their ID number, and then with respect to their ID, their hemoglobin level been calculated or captured, let's say. And then they overall they split that, they considered that, calculated the average hemoglobin level for example, it was a 3,500 plus patient, but for example, we are going to have the for 8 patients, and out of these 8 patients, it says that 10.46 was the mean and standard deviation was 0.69 with sample size with, as I said, 8, and then we are going to calculate the p-value with 6.3. So, and these simple, you can calculate this p-value even in Excel. You don't need to any software, SPSS or any other software. Simply in Excel file itself, you can do this independent t-test. And what's that background for independent t-test? Independent t-test is going to say that our populations that hemoglobin level is going to have is 10.46. That is exactly same with WHO quoted value, that is something with 14. Now here in this example, obviously we didn't split the patient into male and female, but if you split the patients, let's say for male, or let's say these are all female patients, then WHO standards is saying 12 G per DL, and here we are going to get 14.46 as the value G 10.46 G per DL as mean value. So WHO saying see 14 for 12, and we are going to say 10.46. Now with this statistical test, that is one sample t-test, that is independent t-test, we are going to say that this 10.46 is significantly different than 12 or not. That is the story behind that. Okay. And say that if it is a really big, how it is going to be, because insist of 12 10.46, suppose if you are going to have 8.46, obviously that 8.46 to 12 is a big difference as compared to 10.46 to 12. As you are going much more bigger, the difference, mean difference is going to be bigger. Your t value calculated for that independent t-test, the t value is going to be boosted up. And once you're going to be having high t value, then your p is going to be significant. Now again, I'm trying to touch that point that this t value going to be bigger between the difference between this mean value and this mean value 12. It could be other way around also. Insist of 10.46, it could be 18.46 also. Then also we are going to get the p-value is 6. and then you are going to get p-values also significant. But it's never say the directions. By looking this p-value, it never understand that it is in a positive direction or negative direction. Obviously, it will say that, significance difference is there. But significance difference in what sense? Negative or positive sense? You never know. But so, unless and until we are documented the mean hemoglobin in our cohort of 3,500 patients, among 500 patients, the female population's mean cohort, that is 10.46, and mean the WHO standard 12, and then say, look, these are our mean value, and that was significantly different, and that is basically as if below 0.05. Then makes full statement on that. Does make sense on that?
Yeah, for me, like we had already one reference value and we had our data and we calculated the mean from it and we tried to compare our mean with that means with one sample t-test shown here, and we
Yes,
calculated some t-value internally which calculated the p-value. And again,
exactly.
this the p-value didn't mean the site, because now we have 10.46. If we also had higher than 12, which is maybe we say 13.46 or 14.46, we would also have a significance there, but the difference we won't have been seen from it. So,
Exactly.
which is what we
Exactly.
see here with the difference that we quote, like 12 minus 10.46 is some difference,
Yeah,
and
yeah.
the p-value.
Another thing is that this is a byproduct t-value. Based on the t-value, we are going to get the p-value.
P-value.
People many times get confused. They started to document t-value. We no need to document t-value. Okay,
Excuse
people
me,
get
sir.
confused the p-value and t-value. Don't document the t-value. You need to only consider this mean value, both the groups as well as the p-value. Yes, somebody was saying something.
Yes, sir. So that
Yes.
means the one sample t test which we have applied for this study, that result has been given as t value as minus 6.31.
Yes, t-value.
And that
Yeah,
yes.
t-value is minus 6.31. Yes.
Okay, so that means to find out the significance p-value or whatever it is coming, like 0.001 in this case, so we this has come with the t-value as well, right? But
True
usually
t-value.
they don't give
True
us the
p-value.
t-value. But they
No
don't give
need
us a
to have.
t-value.
Yeah.
Okay.
So so t-value is basically, since we are going for independent t-test, it's called t-test. That's why the t-value is going to be having. We are depending on t-value to get the p-value. And t-value is high, significance likelihood the p-value will be low. T-value is low, your p-value will be high. As you said correctly, yeah, exactly the same point. We no need to say that t-value. We need to say only this mean value for female population as well as WHO standard that's already documented in your manuscript, and then say that the p-value is below.
As we did here, so for one sample, there will be some two samples where we are going to check for two groups at a time. Right
Yes.
now here we are doing for the one as reference. So
Yeah.
do you have
Yeah.
example?
Oh, don't. Yeah. One terminological, disturbance always there. So one sample does not mean the only one sample person.
Okay.
One sample means it's a group of one sample groups. People get confused sometimes. One sample means only one individual USA. No, it's an group of individuals from one sample, one type of group of individuals, or only one single type of observations. Same thing could happen for this, uh, um, um, independent t-test. So I'll come it later. Another story behind that. So this is one sample.
So one more
Yeah.
question, please. Sir,
Yeah.
in the previous one, like whatever is the sample, like the data whichever is given to us, how we will know that which type of t-test we have to apply in that sample? Like when to apply one sample t-test and when to apply independent t-test. So will it be covered later, this part?
Yes. So it's depends on the scenario to scenario, how you are portraying your data, how you are calculating your data. That's decide that you are going for one sample t-test or independent test. Anyone want to say anything about what's the difference between Akash? Would you say what is
Yeah.
this one sample t-test and independent t-test difference on that?
Yes. So I would take the difference. Give an example here. For example, we are doing a observational cohort study where we are not doing any subgroup of the patients. Suppose we are going in the population and we are taking their hemoglobin as we saw here. That's what that study meant. They are taking hemoglobin count from a cohort of patients. And now they want to see from this, they have an evidence. Is the sample or the group which they have is a single group. And now the mean that they get from this of hemoglobin is can they compare with any other cohort or any other evidence outside this experiment? And thus we have here just one group and one mean coming, and we have to compare it with some another references. So here we take it as one sample t-test is useful here because the mean is already a reference point that we will take into our calculation, but not the data of that. So we just have one single group data and mean coming from, and we need to compare it with another something and make a conclusion. This can be zero as well sometimes, but true true evidence outside of this experiment needs to be there, and one sample t-test works here. So a, 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 a very similar to it, where suppose we are doing a randomized trial, suppose, and we have this two cohorts at a time, arm A and arm B. And now we want to compare the hemoglobin of this hemoglobin from two data sets. Then it would take me to two sample t-test, something or independent t-test. Right, sir? So to answer your question,
Yes, sir.
one
Thank
sample
you.
t-test works here in cohort studies and everything where, and two-sided mostly where we have two groups at a time.
One point is that exactly the same things that Akash mentioned. So see, here our comparative group is not with our raw data. It's already published or giving some reference report manual over there. With respect to that, we are going to compare. That's why you are going to have this one sample t-test. But alternatively, when you are going to say that independent t-test, then we are having two groups where both groups data into our hand, like group A and group B, randomized control trial arm A and arm B. Like here, you can say that this independent t-test compared two patients group, where Subramaniam J, they say the lung cancer in never smoker, and the published in JCO question was do never smoker with non-small cell carcinoma differ for ever smoker at age, at diagnosis, tumor size, and other characteristics. Then they have the two group of patients, two samples. How this is works, let's say with this example again. So here is example like they split into smoker and non-smoker, and both the raw data they would be having in their experiment. So earlier one, the group's data was not having. Here we are having the group's data into our hand, and now we are going to make the comparison between these two groups. Their mean is going to be compared, and then we are going to say the same way the story that these people are having significantly different in terms of the value of the tumor size. Here the tumor size among the smoker and non-smokers, and then we are going to make the statement on that. That does it make sense on that?
Yes, sir. For me, yes.
Yeah.
Sir, 1 minute. Sir, this here in the argument, it is like written tails, two-tailed. So two-tailed means the graph which we saw in the first paragraph, the probability value. So it can go to the right side or the left side. Is it saying that this two-tailed
Yes.
value?
Yes.
Okay.
Yeah.
Okay.
Two-tailed gives you the provision, because see, once
Both
you're
the
saying
sides.
the smokers and non-smoker, you never know that which one is going to be higher or lower, because both are independent in nature. So that's why it is better to presume that both groups are having two-tail. Two-tail is a better presumption than one-tail. Once you are very much confident that definitely smokers are going to be having below than non-smoker, then you can go shift your assumptions from two tail to one tail. But for that you need to have much more confidence. That confidence comes supported by other studies, other conducted studies over there. Otherwise, once we are not confident much, better to go with the two tailed, and that's the way it stand on that. Yeah, I think there are some questions, Indrila.
Well, actually, not question. It's kind of a suggestion in the chat box.
Smoker and
How
also, are there,
it's
so we
like
want to know whether this average count is same or HB count is same or not. In such case, we are going to do this too simple. Right, correctly said. Yeah. Okay. So go to this, then pair t-test. Another example. So here, Rustin, they have the define the response of ovarian carcinoma to initial chemotherapy according to the serum CA125. And then they said that does serum CA125 fall significantly with each patient after initial chemotherapy of ovarian cancer. See, that point is that initial chemotherapy of ovarian cancer. So that's mean there are some initial CA125 value, and after chemo there is another measurement of CA125 value, and they want to compare. That's why it is called pair. So pair is essentially going to say that it is a individuals level value, uh, same individuals two time point value. That's why it is called pair. And then halving this, CA125 with 7-4 drop with the log based criteria of the same patient was established as a threshold of the biochemical response with p point lesser than zero point 0. And then we are going to see the pair t-test. So same thing. We are now shifting from independent to pair t-test here. One crucial point is that the patients same individuals pre and post value should be maintained. For example, here we are having 7 individual, both are having both pair of observation. It might happen that one individual are having only pre observation, not post observation, so then we can't consider that individual. Or vice versa, like the persons don't have the pre observations but the post observation is there, still we can't consider that individual. So one thing is that the individuals, both observations need to be captured over there, then only we can make it. So so that's that pair t-test value. And same way Excel, even in Excel you can go with that t dot test with this formula. You can go for pair t-test. And then for Mann-Whitney, another example where until now we are saying the t-test provided your data is following normal distributions. But if your data is not following normal distribution, then we are going to come into other alternative statistical tests, and one of them are Mann-Whitney, and then it's comparing distribution in two groups. So one thing is that we don't have the alternative of the independent t-test, because independent t-test, the sample one sample test, because one sample test, once we are going to say, always we are going to say the populations as a reference, and that should be normal distributed. So there is not any compromise on that. But once you are talking about the sample independent sample t-test, there is a provision that you may not meet your data follow normal distribution. So in that sense, there is an example where pain intensity being taken, then rank those the pain score between two regime, and then they say the compare on that same technique, no change. Similarly, like two groups are having two samples group, formula is different. No need to bother about the formula because Excel could consider on that, and you are going to have the p value on that. Now, alternative of the pair t-test, if your data is following normality, then definitely we can go for pair t-test. But if your data is not following normality, normal distribution, then alternative of pair t-test is pair non-normal change. So Wilcoxon ranked test. Like here, we are having another example where URTC, quality of life value being considered, and then we see that patient significantly deteriorated or not, and then we had adapted it, and again p-value is going to get. Look, here while we are talking about t-test, we calculated t value, but here we are going to have the z value. Here we are having z value. Here we are having another type t value. So point is that every time we are going to pick different statistical test, our way of calculations is going to be replaced different way. But ultimately, our product is going to be having p value over there. That we can rely. There is not any disparity on that.
Sir, if you could please elaborate on the non-normal, like previous slide.
Yes. So non-normal means,
Yes, sir.
so
With an example.
yeah. So for example, this is the typical distribution of the normality. Once we are going to say this is the typical distribution. Once we are going to say that, CA 125 value, we are going to say we are going to test it. Our CA 125 value is following this curve, this bell-shaped curve at pre and post observations. But what happened, for example, in this example, the like Mann-Whitney test, the pain score value, once they plotted this pain score value, like, like x-axis and y-axis, they never get the pain score value was following this normal distribution. There is some statistical test also to test that QQ plot, Shapiro will test. So those tests are additional tests that say that your data is following normality or not. But the point is that in this case, pain score is not following normality. So since it is not following, before applying this, t-test and t-test, your data need to be followed this bell-shaped distribution. If it is a failed to follow bell-shaped distribution, then we are having alternative test, that is Wilcoxon test or Mann-Whitney test, that sort of thing.
Okay. So that means the values, like the groups may jo value hai, like this in the A group and the B group or the C group, the value is written there. That should be in the complete number, or if it is like in the decimal in the range. So this
No,
doesn't
it's
mean.
no, nothing with the decimal place. So
Okay.
see,
Okay.
this data distribution means, so here data distribution, how this distribution is going to come. Let's say these distributions, much more better way. So this distribution, if you are having, let's say 500 people, okay, let's assume this is a distribution. If you are having 500 people, and out of these 500 people, each would be having hemoglobin level, okay, male or female. If you plot that, you will see that hemoglobin by and large is going to be having almost 10 point, near to 10.5. That's why you are getting mean hemoglobin level as 10.46 at this area. However, if you go up there, you will see very less number of people will be having hemoglobin around 14 or 16 or 18. So as you go up, hemoglobin level is going to be, means number of people are having high hemoglobin is going to be low. Number of people. Similarly, number of people are having hemoglobin low, below 4, below 3, below 5 is also going to be low. So this is x-axis is nothing but the hemoglobin level, let's assume. And as you go up, the mean is going to be concentrated here, and here you are having lesser number of low hemoglobin. Here also you are having lesser number of high hemoglobin, and that is anticipated is coming from, if you plot these 500 people hemoglobin or 5,000 people hemoglobin level, this plot is going to be prepared like this, and that is called bell-shaped normal distribution. But if your data is not good, means you are not having very huge number of patient data, if you're not in a position to get 500 people's data, you're going to get only let's say 35 people data. So then you may not get this sort of patterns. Out of 35 people, you may not get, it will not be having so much nice trend over there, because to get a proper 10, you need to have good number of people's data. So in that sense, you fail to generate this distribution, that sort of curve of distribution. Then alternatively, we are going to have this Sorry.
Got it. Got it. Thank you.
So these are couple of Man Whitney is there. Wilcoxon is alternative of pair t-test, and then we are having one way ANOVA. So again, one example is there, and it's quite useful for PSA because PSA is also continuous value. While you are having more than two groups, then you can go for and more the two groups in your sample data, then we can go for one way ANOVA. And the same thing, like here are having low risk, immediate, and high risk. So three groups are there. Earlier we are having two groups, male and female, or sample one and sample two, and we are going to compare between these three groups. Then you can go with one way ANOVA. Again, you are going to get the p value. Calculation is going to be different. Instead of t value, we are going to have the f value. Again, some people may document the f value, don't need to have document the f column or f value. Directly you can go with that mean value for low risk, mean PSA value for low risk, immediate, and high risk group of people, and then document that p value over there. This is one way ANOVA. Alternative of one way ANOVA, if your data is not following normality, that is Kuskala way of calculation. Example is different, and that's the another way of having. And then if you are having another thing is the chi-square biomarker response. So these are the all listed tests. So for example, chi-square comparing rates. So once you documented your data in terms of dichotomous format like yes or no, pass or fail, success or failure, died or alive. So then you can, like biomarker response associations, then we can very much go for chi-square test. Way of chi-square again different, like we have to table that HER2 positive, HER2 negative with PCR yes and no. Then we are going to calculate again. Way is different, but finally we are going to land with this p value. So these are couple of more tests were there. We can definitely share this slide, and I think we are out of time now. Any points, any comments? Let's wait for a couple of minutes more if you're having anything. Akash, Vendrila, Ankush, anything you want to add?
So the chi-square is, I feel the chi-square is very helpful and much relatable as we use it a lot, whether to compare between the two groups, the response rates or male female percentages, creating demographic tables, chi-square, t-test, all this help a lot while defining the data in any manuscript or something further, the baseline characteristics. Uh, and even though in some of the scenarios we are not interested on the paper, the rules doesn't say that baselines to be having p-values, but where we consider in RCT studies, but in observational studies, cohort studies, uh, this or any of the non-randomized comparable study, this test play vital role in understanding or assuming uh, defining the distribution and comparing the data between the groups. So, yeah.
Yeah, so I would say that many times it's very difficult or getting the data in continuous format. Then rather than having yes, no, presence, absence, fail, response over there. And with my experience, I will say if people are going to attempt any statistical test out of 100 times, 80 times percent times they opt or go pushed with chi-square than t-test, because it is very easy to get dichotomous or binary data variable than continuous data. So that's why chi-square become much more celebrated statistical test than anything else.
And in perspective of the p-value, all this test do help in rejecting the null hypothesis and saying that the difference is there, and this difference can be taken to make the conclusion that our drug, our therapy, our regimen is going to work or not based upon this, or we are
Yes,
going to see any evidence in the
exactly.
population.
there is not any change in terms of the p-value context. There is not any change in that null hypothesis context. These are all remain unchanged. This statistical test is basically aligning your p-value generations or performing your null or alternative hypothesis based on the type of data you are having. The way you will look upon the data hypothesis. That's the difference in there.
Sure, sir. This was very helpful. And further, I understand that we are going to have more advanced topic on p-values and statistical test. And again, the designs where the significance level is considered, how it is considered, how the adaptive designs are considering the p-values. All we are going to have the discussions in further pathways of this series. So yeah, thank you. If anyone has any doubt, please open to you. We can discuss on those, because what I have learned about is it's about the scenarios that we come across while doing clinical research. We keep on applying various statistical tests and the methods, and we evolve there based upon the experiences.
Exactly. Exactly.
Yeah, I have a doubt. Can I ask?
Yeah.
Yeah.
So the test which we have discussed today, or ANOVA, one way, and everything, are we going to dive deeper in the upcoming sessions, or how is it?
So we can definitely go. We are going to share with you some, questions or quiz part, and there will be some options to give you remarks, feedback, and please feel free to put your others topic you are looking for. Then we are very much open to adopt other terminology as well. And definitely we can go much more deeper with this different
We
statistical test.
we do want this test to be hands-on. The reason is
Yeah.
Okay.
we'll be using day-to-day life, right? This data will be playing.
Serif, may I add?
Yeah.
Yes.
Yeah. Thank you for this. And we literally want you to do your basic statistical analysis for your day-to-day life clinical research. So yeah, we will be showing hands-on practice of performing the test in our software or SPSS software, whichever you are comfortable with. Mostly both. And secondly, we might not go in mathematical calculation and everything, because that won't be very easy to understand, and it is much time consuming, where we are having softwares and AI to play the role. So yeah, but we'll have further sessions will be designed to give in real example, and how hands-on practice softwares can help you calculate these things. But again, it takes a lot of care while doing, because p-value, again, we know that we are going to make some decisions on it, right? So in hands-on, we will discuss on it.
Yes, please. Yeah, thank you.
Thanks.
Surely we'll touch it.
So I was expecting if you could share the outline of like in upcoming sessions, like what are.
We can definitely. We are also having some outline, but we are thinking based on your feedback, based on your remarks. We want to make it much more flexible and move it that manner. So that's why your participation is, because we may touch something may not be very much linked with you. So definitely we are having some guide, that topics been taught, but simultaneously we want to have much more dynamic sense. So every times we are going to modify the things based upon your feedback. Like today we got that some feedback, so we will work on upon it, and we will touch on that to try to get much more on that. Broadly saying, we are having study design, we are having uh, survival, longitudinal, missing data analysis. Then we are having entirely GSP, good statistical practice over there, and will be certified also having the good statistical practice once you cover this quiz over there. So after having each session, there will be some questions, and then will be MCQ. Then you have to pass it with online. Then definitely we can get the GSP certificate. But and there are various topic been already been taught taught to be covered, but simultaneously we want to also be dynamic on that.
In next sessions, we will go upon further deep with p-value and designs. And as suggested, we'll give an hands-on at the beginning on SPSS software. I hope all of you are having SPSS software. If we would like you guys to have the SPSS software crack versions at least, you can contact Ankush there. He can help you with it.
Yes, we'll ask him.
Yeah. Or in the mail, we will share the Google form link plus the outline, which has been decided for now, and the SPSS software link. So in next session, we will also touch upon the hands-on for this and further carry on with our sessions. Okay, sir. Then I
Okay,
hope we look you all in further sessions as well. Thank you for connecting. Thank you, Atanu
Have we
sir.
have
Thank you,
this
Andrila.
video now? I think we are having video now, recording now.
Yeah, we are also
So-
recording this.
Okay, good. Who is going to save this recording? Ankush, are you going to save this recording?
Yes, sir, I will share with you.
Okay, great. Thank you very much, all of you.